Okay, folks, let's go ahead and get started. Thanks all for joining. We're excited to welcome you here to Trella Health's webinar on value-based care and how to partner with ACOs. So a few housekeeping rules before we get started. So attendees are in listen-only mode. So if you have a question, you see a Q&A at the bottom of your screen, just go ahead and click that, enter your question. We will get to as many as we can in the session, and anything we don't get to, we will take care of outside as well. Okay, we are recording the session for those unable to attend, and the recording will be sent out to you. Thank you. Our speakers today, so we have somebody who is very well versed in healthcare market, understanding what's going on in Washington, DC, what's going on with CMS, has a pulse on the trigger for ACOs, and really truly navigating, analyzing, looking at the market across a broad spectrum. We have VP of Product Management at Trella Health, Rebecca Molesworth, and myself, Sam Tooley, Product Manager at Trella. And we are excited to have all of you here today and hopefully give you some good insights. Okay, so a little bit about Trella before we get started. So we are a performance analytics and market data company, okay, supporting smarter growth, healthier outcomes. We are a market leader, and some of the data points we use for that, we are in 7 of the top 10 largest home health providers, okay, so heavily post-acute focused, okay, 6 of the 10 largest hospice providers, 2 of the top 5 skilled nursing facility organizations, and across those we have over 10,000 users, okay, from over 250 customers, and that's growing tremendously. We're seeing great growth even in 2020. Okay, because of what we have available to clients. We have over 1 million Medicare lives. One of the biggest keys, of course, in many systems is the data. What do you have access to? What can you glean? Insights are only as good as the quality and integrity of the data that you're looking at. So we actually have 100% of Part A and Part B claims. We have 100% of MA claims, and we have more MA data coming imminently. Our data is updated quarterly, and we essentially have over 1.2 billion claims analyzed across 62 Medicare beneficiaries. We have a great pipeline of customers with 10% accelerated growth and a 98% customer net retention. So using all of that, you can tell that, you know, we are very focused on what we do. We are committed to delivering quality and a product that actually meets clients' needs, and we'll talk a lot more about that.
Great, thanks, Sam. So I'd like to just quickly go over what our roadmap is for the day. We're going to start by looking at the market a bit. I'm starting from the market side looking at the pressures that are forcing more focus on provider relationships amongst providers that may not have collaborated as closely as they're going to be in the future. We're going to overview what accountable care programs are and which ones are out there. We're going to take a look at some of the market research that Trella has been doing in the ACO space, and we want to be able to share with you some of the key findings and insights we had, especially around the post-acute care space, and what impact that has on partnerships for our post-acute clients with ACOs. And then we want to open it up for questions and discussion, and we've had some questions and discussion come in already, so we'll pick from those, but also those that come in during this call, and like Sam said, we'll make sure that if we don't get to something that you've asked us that we follow up with you so that you have at least our input and thoughts around those questions. So just starting a little bit from the market itself, if you look over on the left-hand side, you know, a lot of what's happening especially in the post-acute care space because of the audience that it serves is being driven by Medicare and Medicaid policy from CMS. And so there has been an increasing pressure over the years to move away from a fee-for-service model, which is what you're seeing on the top here, all the way down to more of a population-based payment model. Seema Verma, before she left office, said very clearly that CMS is trying to get out of the fee-for-service business. That was reiterated by Brad Smith of CMMI on a call we were on not too long ago. But certainly fee-for-service is where we have been. And so if we look at sort of the track record of how our health system has been tracking over the years, you'll see the obvious rootedness in fee-for-service models. And then over time, we're starting to see some of those models add quality and value to the contracting around reimbursement in the form of bonuses and things like that. PDGM, PDPM coming into the post-acute space, starting to assess the value of the services that are being driven. And by value, it's a combination of cost and quality together, equaling value. And what I think starts to get really interesting is when you look at where the ACA pushed us into these advanced payment models that were built on top of the fee-for-service model that we have in place today, you start to see other groups getting a lot of pressure from CMS to shift how they do their business and how they're serving the cost and quality of CMS overall. And you'll see that that's where we start to see our risk-bearing entities. So those advanced payment models, those APMs, including things like ACOs and the new models of DCEs, start to come into play here. And then on the sort of farthest end of the extreme with population-based payment, the place where CMS wants to end up, we're starting to see more and more activity there, specifically on the physician group and the health system side. That's where they went after first. But as you notice by the MA carve-in and some of the quality programs that are coming, those population-based payment models are starting to be enacted. And specifically when we talk about, obviously MA plans have been capitated for a while, but DCEs, direct contracting entities, have a global payment, global capitation option to them. And if those DCEs are under the global payment model, all of the services that a member, a beneficiary gets will be included in that capitation. And that's when it starts to get really interesting for our post-acute friends, right? And so we're going to continue to see that trend. We're going to keep seeing that downward pressure pushing people into these global capitations. And what that will do is put pressure on our post-acute system to start thinking about how it delivers care and probably change some of the ways that it's working, such as happened with the physician groups and the health systems earlier in the 2010s as they started to look at some of these models. So let's just take a second and talk about what accountable care is. It is an accountable care organization really is based on a few specific attributes, and it's where providers are coming together to pick up the payment risk as well as the care delivery risk for specific populations. They are traditionally made up of different provider organizations, and they're really focused on providing the right care to the right people at the right time and in the right place. So place of service becomes very important in this model because you're trying to find the lowest cost care setting for the best quality and outcomes. And they are trying to avoid unnecessary care, obviously, and they're also very anxious to push reward and risk down to their partners as well. And that in and of itself starts to shift how the market is working. So let's talk a little bit about the history of ACOs. Sorry, my clicker's not clicking. So back in the 80s and 90s, and I was around for them. I was pretty young. I was very young, but the HMOs that came out were really an attempt to try to manage the cost and quality of care through controlling where people had access to care. And we know that sort of failed spectacularly in its way. And I'll just, as a plug for data and analytics, say that one of the reasons that it was such a struggle and why the industry ultimately rejected it was the data wasn't there. And with the coming in the 21st century of new forms of data, the ERA High Tech Act, adding the ACA, you're starting to see the data become available, and most recently ONC and CMS have both put non-data hoarding rules out there to establish more ubiquitous sharing of data. And that's allowing these accountable care organizations to thrive because they now can see what's going on where before they could not. So in 2005, we started that accountable care journey essentially with the physician group practice experiments that were going on, and they were looking at how they could drive more valuable care for a better cost and better outcomes. 2006, this term ACO first came up, and I want to credit Health Affairs. I may be not right about that, but I think it came out in an academic peer-reviewed journal, a study that said that seniors tend to, once they choose a provider, they tend to stay with them, which would make this idea of accountable care without curbing patient choice, which is the key, possible. And so by 2010, when the ACA came around, we now have this ACO model and what that means written into the law. It also established the ACA, the CMMI, which is the innovation arm of CMS, which allowed CMS to carve out experiments to start to change how the value of care is delivered in our country, and test out these new payment models that they're interested in. And that became really important because what you're going to see now is the sort of reiteration and the rapid experimentation of CMS with lots of different models. They all sort of build on each other, which is why they're confusing, and it's hard to know who does what and which one has which rule. But it was the beginning of the iteration process of CMS, trying to explore how do we end fee-for-service and go to a model that's more controllable. Pioneers started in 2012, MSSP, which is the Medicare Shared Savings Program, those followed shortly thereafter. Next Gen ACO was a new ACO model that was building on the successes and failures of the Pioneer and the MSSP model. And last year, they changed the MSSP model into the Pathways to Success program. And so as you can see, they kept iterating over and over, adding new tracks to the MSSP. And now here in 2021, we have the beginning of the Direct Contracting program. And we'll talk about that more in just a minute. It's technically part of the Primary Care First program, but it is built upon all of the success of ACO experimentation that CMS has been doing for the last 10 years. And so in a way, it is an ACO in and of itself as well. So types of ACO models, I've mentioned them a little bit. The pioneers started early, and they were mostly health systems that had some experience with taking on risk. It was not, it was not for the faint of heart because you were jumping in completely blind. CMS was figuring it out as they went, as was the pioneer ACOs. There was risk and reward in this model, and you'll see that over time there was a lot of attrition. It was the first foray, and so there's a lot of lessons learned. Some learned they weren't as ready for risk as they thought. Others were able to successfully manage it. But moving into the MSSP, where there was more upside risk in the early days and less downside risk, you saw some of those models, folks move over into that model where they could handle the risk problem a little better, continue to refine how they did their business, and try to make the MSSP program a success for themselves. Next Gen, again, offered new ways of thinking about ACOs. I think one of the biggest things that it did was it made the financial targets more predictable. They took a good hard look at the benchmarking and how they, prepayment and things like that to try to make it less dangerous for an organization to take on that much risk with a retrospective attribution model. And that retrospective attribution model is a big deal. It's really what makes ACOs different than MA plans, not the only thing, but one of the key things where MA plans know who their population they're serving is. They can account for the risk of that population. An ACO is retrospectively being assigned people who got their care and services from the ACO network after the fact. And so anticipating the risk and actually being able to manage it is much more challenging in an ACO environment. So let's talk about direct contracting just for a moment, because it's a critical part of where ACOs are going. There are 3 new models. They started their implementation period in October. They are going live with their first performance year on April 1st. There are 51 signed up for the implementation period. I believe there's an out clause. So if they get to the end of the implementation and they think, oh, wow, we're not ready for this, they could decide to defer and not participate in the first year, but expecting about 51 groups to be doing this. Some are standard, which that type of ACO is geared for someone who has risk, has taken on risk, is comfortable with risk, They're starting with a minimum of 5,000 beneficiaries in their model. The new entrants are for just that, people who've not taken on risk before. And so these are separate legal entities that are being formed in order to manage a patient population. And the ones that are coming in the new entrants are actually really interesting. And I expect to see more interesting ways of managing care outside the standard medical practice or health system as the new entrants into this DCEs. In fact, I believe there may even be a couple of post-acute care organizations that are either considering or are participating in this first year as direct contracting entities themselves. And then there's the high needs entrants, which are very specific diagnoses and medical needs that are a much smaller population of very, very sick individuals. Folks who have a lot of experience taking on very sick populations are looking at that high needs, that type of DCE. And then there's a couple more they've announced but haven't really launched. One is the geographic DCE, and that is based on a geography. And then we have the Medicaid MCO-based DCEs that'll start next year. And that program's interesting because it's getting into the Medicaid space. I think this is one of the first like Medicaid, risk-based type programs that to the scale that they're doing with this population. So it's going to be interesting to see how that comes out. So with that, I think what we'd like to do is do a quick poll and get a sense of how you guys have interacted with ACOs in the past. And so the question we want to ask, and Ashton, if you don't mind hitting the poll when you get a chance. Perfect, there we go. To what extent are you currently partnering with ACOs? So the answers are we currently are working and have established ACO partners. We are in discussions with ACOs about a preferred partner relationship. We're looking to partner with ACOs in the future. We haven't started to partner with ACOs and we want to learn more about them, or we have absolutely no interest in partnering with ACOs. So hopefully we got enough of a spectrum of choices there that you can find something that aligns with how your organization is thinking. And then we'll give you, I guess, like 30 seconds and then to click your results, and then we'll share the results with you so we can see. We have, it looks like about 280 people on the call right now. We should be able to get a pretty decent sample size to see where people are in terms of their relationships with ACOs. All right, so it looks like our poll is over. Oh, wow, cool. So 38% of you already have established ACO partners. That's great. 17% of you are in discussions about a preferred partner relationship. 20 are looking to do this, and 21 are looking to do this in the future. And 23% haven't started to partner with ACOs, but they want to learn more about them. And we have 1% who have no interest in partnering with ACOs at all. So that's an interesting mix. It sounds like there's a lot of folks who've started to sort of foray into this space, and I'm looking forward to hearing more about your experiences when we get to the questions and discussion. I think there could be some really interesting conversations we have there. So great. With that, let's move on. I'm going to move us ahead, and you can hide the poll for us.
Yeah, so let's talk about top priorities for ACOs. What are ACOs looking for? What are they interested in? What are they focused on? And how does that impact you? Next slide. So, one of the things we did here at Trella is that we did a lot of market research, right? Really talked to a number of ACOs across the spectrum. We talked to a variety of leaders, those that are executives, business developers, building out their networks, performance leaders, who's looking at quality, a variety of ACOs. Also groups, right? So we looked at groups versus those that are individual. Also looked at payer mix, so across the Medicare, Medicaid, fee-for-service, commercial. We looked at ACOs that had smaller beneficiary counts, right? They may have been 10K or lower, all the way up to 100K beneficiaries in their networks. We looked at single ACOs to groups with multiple ACOs. We looked at hospital affiliated or as well as independent physician-led ACOs. We looked at a variety of payment models and tracks, those experienced with bearing risk, those who are new to the risk-bearing market. So, all in all, to say that we really took a very broad approach to understanding what is an ACO, what are they looking for, how do they want to grow, what's of interest to them, and how does the post-acute care fit into that mix as well. So we'll talk about what we learned and that's fine, go ahead, thanks. So you see here the priorities that they're focused on, right? So the top two priorities essentially are managing quality and managing cost. Now, that doesn't mean everything else is lower priority. It's just that that's the initial focus. And as ACOs mature, they start looking at some of these other priorities as well. And so you'll see that sniff utilization, post-acute care, those types of things are other priorities listed in the top three, and definitely of interest to ACOs. Next slide. So, some of the questions we hear or we've seen, what are ACOs actually measuring? What are they interested in? What are they focused on? And so you have some of these key metrics over here. We started that research with Levitt's accountable care learning, collaborative feedback. We did a lot of market research with the ACOs, as we talked about, and some of the key metrics essentially came out to be, what is the cost? What is the per member per month cost? What is the per member per year cost? How are those things trending? What is the risk breakout of my population, right? Do I have a high risk population? Do I have a low risk population? What are my readmit rates? What are my ED OBS visits rates? What are my inpatient admissions? What are my sniff admissions? What are my network leakage? How many people are going in versus out of my ACO network, right? So there's a lot of metrics. And then what we're doing beyond that is actually drilling down to the provider level within the ACO for these metrics, right? So what we're showing here is at the ACO level. So now I know how my ACO is performing. I can actually compare that to other ACOs. I can look at CMS benchmarks. I can look at benchmarks that I set myself, and then compare and watch my trends, right? Progress over time. Next slide. So this is understanding a little bit more about cost. What are ACOs interested in when they look at cost? And when we say cost, what does cost mean? Right, so ACOs typically are paid PMPM, right, per member per month, and so they're looking to keep their cost as low as possible below that value in order to increase their shared savings. So one of the things that ACOs are looking at is how are my costs trending, not only month to month to identify how am I doing seasonally, but also year on year, right? So is June typically a high cost month for me? Can I manage that better, or is it normal? So we have year-on-year comparisons. We also are able to, based on the CMS benchmark, identify how we're tracking against that benchmark. And you'll see down below in the grid, we actually capture a number of metrics related to cost, right? So now we're breaking it up by the providers within the network. Okay? So not only do we know the cost PMPM at the ACO level, but we're also looking at it by providers. Now we can see who are our high cost versus low cost, who are providers managing higher risk patients versus lower risk patients, who are managing more patients versus fewer patients, right? So we have a much better understanding of what our patient mix is, what our cost makeup is. Next slide. So the interesting thing here on this slide is we're looking at patient pathways. So what we're trying to do, what we actually do here is understand, okay, where are my patients coming from? Where are they going? How many are going, for example, from hospital? Where are they going? Are they going to SNFs? Are they going to home health? Are they going home? What's the makeup of that population and who's managing those patients, right? And then even from let's say they end up in a SNF, or home health situation, do they come from the ED? Do they go back to the ED? So we get a better understanding of where patients are going, what facilities they're using as well, right? So if you're a post-acute care facility, you can actually see within the ACO, is my facility being used at all? If it is it being used heavily? Do I have opportunity for growth there? Okay, so plenty of opportunities to see, really understand where are these patients traversing the healthcare system. Next slide.
So as we're seeing this increasing emphasis on ACO in the market, ACOs are also increasingly starting to look at post-acute care. And we had some really interesting feedback on how post-acute care played into their plans, acknowledging that it was important, but where it fell and how they were using it was very different. So one thing we learned is that building a quality network is really hard, not surprisingly. And it's interesting how these ACOs were pursuing and managing these networks. They normally started with PCPs for obvious reasons. That's what drives the attribution. That's what drives who is in their population. So they want to make sure they have a group of PCPs that are effectively managing their patients. Then they're worried about inpatient cost. And, you know, as they're starting to look at quality of inpatient and post-acute, they found it really hard to evaluate. We heard that over and over again. Some of the things that they were looking at was if they had data, they were looking at readmission data, they were looking at ED, some of the things that Sam was showing on an earlier slide. And they're constantly trying to figure out how to identify who's performing well and who's not. And so as we talked about earlier, the data is so critical for being able to actually really manage a patient population through the provider partnerships that you build. And one of the things that they said off and on was that lots of times they had a hard time being aligned with their partners. You know, an ACO has a cost and quality mandate that is unforgiving. That CMS benchmark is set and it is where it is. And they were struggling to get the partners to be aligned with working that way with them because they have, you know, they have some very clear goals that they have to hit. One of the other things that was interesting, I spoke to one ACO leader who said, you know, we were so focused on our PCPs and our acute care that we didn't even think about post-acute in the early days. And that as the ACOs matured, post-acute became more and more important. I think also, if you remember that first slide, moving towards global capitation also makes the post-acute more important too. And so as time goes on, as ACOs mature, as the business processes around them mature, and as we have more and more contracts and more global capitation contracts, you're going to see more and more interest in post-acute. And one of the other things they're doing, certainly with PCPs and specialists, it'd be interesting to see how much this is going down to post-acute, and we don't have that data element, unfortunately, is that they're starting to use coding. They're looking at how services are being billed to understand what the post-acute or the provider is particularly good at and how that aligns to their goals. And so some of them are getting pretty sophisticated on how they're thinking about quality and how they're thinking about utilization as well as cost. So when we asked folks, you know, we asked everyone, how much are you focused on post-acute care? How much does it matter? And so what's interesting is, even though it was not in the top 5 things that people thought was their #1 priority, over 95%, I guess 94% said that it was at least somewhat their focus, if not very focused on post-acute care. So clearly they understand the impact that post-acute care has on their cost and quality. Whether they're able to get to the place where they're really managing it well or not seems to be another story, which, you know, from my perspective, offers a lot of opportunity. And when we started to drill into, well, which type of post-acute are you more focused on? Same set of respondents, they undeniably said their first priority was sniff. And when asked why, at least a couple of them said it was because of the dollar amount. So if you're, you know, following the story, it starts to become very clear, right? They focus on the PCPs to build their growth. They focus on the inpatient because of the highest cost value comes from that inpatient area. And then they're focused on the sniff. And then they're looking at home health. And finally, hospice, although you'll see their hospice is a priority throughout for some. The opportunity with hospice is pretty huge. And I'm not sure that all of the ACOs have been able to think far enough ahead to be able to see the value that appropriately using these post-acute care settings can have on their bottom line.
So, so the question becomes, how do you demonstrate your value to ACOs, right? The question on most of your mind. And so let's go into a poll question again, our next one. Okay, so what challenges have you encountered in attempting to partner with ACOs? Okay, are you having issues identifying who your ACOs are in your area? Knowing what would make your organization compelling to ACOs? Knowing which ACOs best align to your strengths? And knowing who the ACO is already partnering with and how to position against them? I'll give it about 30 seconds and we'll share the poll results. This is where we need a Jeopardy clock to time down.
Well, it's interesting. We'll see how we did with guessing what the most challenging things are. And if we miss, you guys can tell us.
Yep, so we have all of the above.
Someone put that on the chat. It's cool.
Okay, so knowing what my ACOs are, 16%. So number one is knowing what would make my organization compelling to ACOs, 39%. Second, knowing who the ACO is already partnering with and how to position against them, 31%. Knowing what ACOs are in my area, 16%. And then knowing which ACOs best align to our strengths, 14%. And I imagine there's a number that are probably all of them. Thank you. So let's talk about that. Next slide. Yes. So how do you demonstrate your value to ACOs and what are they looking at? How are you being evaluated? So based on the type of facility, right? They're looking across the board, they're always looking at patient risk, right? What level of patient risk are you managing and how well are you managing those patients, okay? Of course, cost is always going to be important, right? Both risk adjusted primarily based on that risk score. And then readmission rates for SNFs as well as home health. They're looking at hospitalization rates for SNFs, length of stay, okay? Your star rating, and then your admissions. And then home health, you know, similar, also looking at readmission, star rating, admissions. And then hospices, again, looking at hospitalization rate, length of stay, patient admits. You know, some of the other things they may be looking at is where do they go after these facilities, right? You know, in the case of hospice, you don't necessarily expect them to go home, but there are some that do, right? So there's potential opportunities there as well to better manage those patients' care. Next slide. Okay. So considerations when partnering with ACOs and other value-based care entities, okay? The post-acute revenue is still predominantly driven by fee-for-service. You know, that is weaning off, moving more towards the value-based care spectrum. And that market is actually, it's here to stay and will accelerate over time. As Rebecca mentioned earlier, right, CMS is looking to move away from fee-for-service into value-based care. And, you know, with the current administration, that's likely to accelerate even more into value-based care. And we can see ACOs getting a little bit more innovative and growing and having more interest to partner with post-acute providers as well. Okay, from the post-acute side of things, you essentially, because of this direction that we're going in, are really having to identify how do you become a preferred partner, right? How do you identify the ACOs to work with? How do you get those referrals? How do you build into those networks? Right? So you've got to start building direct relationships with these entities and become that preferred partner. Okay? And that comes from, again, understanding your cost, your patient mix, your risk, your utilization, your quality of care. Okay, so essentially, it's here to stay. It's going to grow, and the market will shift, right? So you're going to have to start looking at a hybrid fee-for-service, capitated payments, right? It's a changing model. It's a changing healthcare world. Next slide.
So, you know, as you're thinking about how to partner with ACOs and other value-based care contracting entities, there's some questions we think would be helpful in terms of how you plan your strategy. You know, one being, how do you compete and not get shut out of a preferred network? I mean, just today, we were on a call with one of our customers who is participating in an ACO as network as a preferred provider, and said they've had competitors try to get in with that ACO, and the ACO has been pleased enough with the work they're doing with this particular hospice agency, they haven't let the others in. And so there is this sense of how do you find a way to compete with what you do and how you're, you know, where your strengths are in order to make sure you're not the last person out. The other thing is, you know, when we talk to folks in looking at these value-based contracting, one of the things they ask is, you know, well, how am I going to be able to protect my rates? And I think that's one way to think about it. And as you try to deal with this hybrid world, this happened with the health systems. For, you know, a lot of you probably saw or experienced it, where as the value-based care started coming into their world, they were doing this, the finance folks were doing this juggling act where they were saying, let's make sure we maximize the you know, the piece rate work we do, because we get better dollars for fee for service, but we don't want to be not participating in this value-based world because we know it's coming. And we got to figure out how to balance our revenues on both those sides so that we're not cannibalizing our good revenue with less valuable revenue, but we're learning how to manage and how we can be operationally efficient while doing that. And I think you're seeing a lot of health systems still in that place where they've got one foot on each horse and the horses are running off, right? That's going to potentially be part of your world as well. And in doing that, it also will probably beg questions about how you operate. And are you prepared to either take on services that are needed to manage patients across the care continuum better? Can you be the partner for the ACO and provide the services that are going to holistically take care of that patient at the price point that the ACO is going to pay you? And in that, are you willing to let go of some services that may not be value add that previously you may have been able to bill for? And then how do you gain access to as many networks as possible? Another thing to consider, right? There's going to be a bunch of ACOs out there. It's a changing world. Some go away. More will come with the direct contracting entities. Again, some interesting new entrants in there that may be looking to compete in a different way with this market. It's, you know, it's a game of how do you prepare your business for being able to hit this transition without it taking you out of the competitive market. So that's a lot of, I mean, I'm not trying to scare folks, but I think those are big questions that are helpful to ask. And so when you think about what can you do around how to manage this new world you're entering in, I mean, obviously having a full view of the market and being able to actually see the ACOs, what they're doing, where they are, who they're partnering with, being able to look at your competitors and how they're participating with ACOs and how the work that they're delivering is impacting the ACO's cost and quality. If you find that you are able to deliver more comprehensive services at a better price point with a higher rate of outcomes, you become very competitive and an ACO is going to be interested in partnering with you. It's going to be your ability to compete on cost and quality that is going to get their attention. As we talked about very early on, their number one concern is cost and quality. So how you fit into that story is going to be where you build the secret sauce that drives the value that these ACOs are going to want. And being able to use the idea of the beneficiary attribution, which is confusing, and it's logic that CMS has driven. You can use that attribution logic against data to be able to see who would likely be a part of that ACO, and being able then to help that organization not only understand who is in their ACO, because they're waiting for CMS to tell them, again, retrospectively, but being able to say how you can impact their cost, their quality, and the level of utilization going on in the organization. And then knowing your strengths. This is stuff for our MarketScape clients who are on the call with us. There's a lot of information around your strengths in that data. On the Mosaic side of the product suite, there's a lot of information about your strengths and what you can do on the ACO side. So there's a lot of cost and quality data out there when you leverage it, and it's that allows you to come to a conversation with an ACO with data that is showing your understanding of their business and their needs and how you fit in and make their lives easier. That post-acute world is fragmented. There's a lot of folks out there. It's hard to wrangle, and any way that you can make the ACO's life easier to know that when they send someone downstream to a post-acute, post-discharge, they're sending them to a post-acute agency, that they can trust that the agency understands their goals and that they're helping respect and represent that as a good partner. Will help them refer and fill your beds, fill your roster. And to remember, partnership's a two-way street. It's a new world, and the way that our ACOs are being set up deliberately is forcing that partnership, and that, in fact, is the design of the ACO. And so I think that a lot of post-acute agencies are going to have to think about how they partner with these different organizations with a slightly different energy than maybe previously, just because you guys are going in it together, right? And either win or lose together in this model. So with that, I think we have one last poll question that we'll head to. This one we will not share the answer to. Broadly. So the poll question is, are you interested in learning more about Mosaic? That's a lot of what you were seeing screens from here today. That's our product that is geared towards ACOs and looking at ACOs and their networks. If you're interested, please feel free to say yes. We'd like to be contacted, and either a CSM or one of our sales folks will reach out. If you're not interested, that's okay. You can tell us that too. And we won't share this one for everyone. But if you have said you'd like to see some more, we'd be happy to talk to you more about it. We, just like we have a collaborative that gets together to talk about MarketScape and where it's going, we also have one for Mosaic. And our DCE clients are using that advisory board, and we're just starting it. So they will be using that advisory board to come together to talk about what they care about and what this new model brings to their needs. So there's a lot of exciting learning going on in that space. And of course, we would love to have you all join us. So with that, I think we will close the poll, and I'm going to open this up for question and answers. You'll see in your, what do we call this? Your console panel, there's a Q&A button. It looks like we have been getting some in. I will put these over here. And we can start answering any questions you might have. We have about 15 minutes before the top of the hour, so we should have some time to look at some questions. So let's see. Okay, here, I have a couple here. So the first one we have is, for us in the post-acute space, is there a recommended strategy in terms of number of ACOs to work with? Do ACOs prefer us to be exclusive partners, or should hospices try to work with all ACOs in their service area? I think that's a really interesting question. The example of the hospice that I was talking to today, they are looking at other partnerships. I think it seems like an approach of, get as many partnerships as I can is going to be an important one for making sure that you're getting as many referrals. I think the name of the game switches from how much can you do with one person to how can you keep your beds full and the quality good with people moving through. And so the more, if this from a sales perspective, the more referrals you have in your funnel, the more likely you are to have a full set of folks to treat. Another one is the local hospital owns their own home health and hospice. There is a non-hospital owned home health and hospice. What benefits would the hospital have to use a non-hospital service? That's another good question, and it's a tough one because obviously there's going to be an incentive for an owned service, if it's part of the hospital system, to do that. to use their own services. I guess I would say that one of the things that you can do is in having a conversation with them using data to say, hey, here's how your own home health and hospice are performing with this particular type of population, and look what we can do. Hopefully better, that will hopefully open up the door to give a better conversation. But it is a tough play, right? Obviously, they're going to prefer to send the patients to their own system if they can. But if you have abilities that they don't have, if you have specific strengths, say respiratory, or you're really good with cardiac patients, or the cancer end of life is where you guys really excel. Showing that to the home health or the hospital system or the ACO to say, you may want to add us to your roster as another partner because we can help manage those patients a little bit more effectively than you've been able to do so thus far, might be a way to get your foot in the door. Let's see.
I can take one here.
Yeah.
There's a question on what is the Mosaic side of the platform? Is that a separate platform to MarketScape, and how does one get Mosaic? So yes, Mosaic is different to MarketScape, and we can certainly set you up with a demo, introduce you to a customer rep who can show you that and give you more information on how to move forward with Mosaic and see what that has to offer.
Another question is, how do we get a full view of ACOs? That is part of what Mosaic is designed to do, actually. It is looking at the world from the perspective of the ACO and their attributed populations. And so we have clients that are ACO DCE clients that are interested in using that data to understand who's being attributed to them before they wait for the CMS readout, so they can start to make changes and manage their network more efficiently. But in the same way, there's also all that transparency around all the ACOs in the market that CMS has that you would have access to be able to see who the ACOs are, who's in their network, how many patients they're serving, what kinds of patients they're serving, that sort of information.
Yep, there's a question here on what is HCC. I mentioned that a few times, and that is essentially CMS's risk adjustment model. It's a hierarchical condition category. And what CMS does is when they want to compare apples to apples. So when you have a patient who's high cost or high risk, let's say they have ongoing medical conditions like diabetes, COPD, or heart failure, that high cost or high risk patient is different from somebody who had an injury and it may be short term. That's an example of an ability to risk adjust and compare like to like when we're looking at cost and other metrics.
I'm looking, I think I missed the explanation of what the new Direct ACO model represents and how does it differ from previous ACO models. Yeah, so the direct contracting entity is part of the Primary Care First program, but it is essentially a culmination of all of the other ACO models that have been along the way. Some of the rules differ. The attribution models are slightly different. The benchmarking, financial benchmarking criteria is slightly different, but it's basically a more fine-tuned version of an ACO. I would also say that it is much more risk intensive. So where you're somewhat protected in the MSSP model about what risk you take on, with the direct contracting entities, you could actually be taking on full risk for the full population and have a lot more upside potential. So the more risk you're taking on with CMS, the more upside you have. There's another one here with the current crises of personal health care, or personal care in the acute and post-acute space. Sorry, let me try that again. With the current health crisis in personal care in the acute and post-acute space is now a very important partner in the care continuum, including ACOs. Why is this important segment not being included or identified or data being collected? I think that's a fantastic question, and I don't know that the answer is that it's not. I think the reality of the data that Medicare is collecting and saving is based on the billing, because that's what they have control over. They're a payer, so they know what's being charged back. Another interesting, and this is a side note, something really interesting is that once we start to have more global capitation, all that billing data becomes much more ubiquitous. It's not going to have the same level of granular detail because we're not billing service by service by service. So that's going to change our data sets infinitely across the healthcare market. But I'm not sure that the data is not being captured. I think when you start to look at care coordination, you start to look at social determinants and other things that people are doing around managing the patient population. I believe in EMR systems, they're trying to collect more of that data. It's just not part of the active billing cycle for Medicare, which is why we don't actually have access to that data directly today. That doesn't mean it's not being captured though, but I hope that answers your question. And if you want to talk more about it, do I think it's an important area? Yes. It's one actually we're personally as a company we've been looking at. We're interested in private duty and its space in this non-acute setting. So I would love to have another conversation about that. Is there one in there you want to grab, Sam, or shall I go to another one?
Go to another one, I'm looking.
Okay, let's talk about, we just got one in on beneficiary attribution, and please know if we're skipping one, there's a lot coming in, which is fantastic. We'll go through these carefully and make sure we respond to all of them so that we're not missing any. But beneficiary attribution is important. The CMS model for fee-for-service, part of the main tenets that the legislation has is that you can't disrupt the patient's right to choose where they want care. In MA plans, you can say, you've chosen your primary care, that primary care doctor is going to direct you to the most cost-effective, valuable care. And that's one of the ways that MA plans can manage cost. With fee-for-service population, it's like an open network. They have to be able to go to anyone that takes Medicare. And so one of the ways that CMS is getting patients attributed to an ACO is by this attribution model. And essentially what it does is it looks at, I want to say up to 3 years of claims, depending on which model you're looking at. And it's looking at the plurality of care. It's technically, I believe, the plurality of E&M code costs that are attributed to a given provider or a given provider group, depending on which model we're talking about. But if you essentially think about it as whoever had the most care with a specific doctor gets attributed to that doctor. What's interesting and scary about it for folks who are entering from the MA side of the world is that that can change. So one year, let's use me as an example, I go see my primary care doctor, Dr. Smith, 4 times. And in the ACO research that was done, they basically said seniors tend to stick with the same doctors, that they know and love. But say in that year, I saw my primary care 4 times. For whatever reason, I had 4 reasons to see him that year. The next year, I went to my first appointment with him, like normal, my quarterly visit. And then I had a heart attack. And then I started seeing a cardiologist who was performing E&M type services on me as he's managing my heart condition. So for that next year, I could totally be moved to a different physician, to the cardiologist as my primary care physician. And they control which specialties are allowed to be primary care. But that attribution is fluid based on where the patient chooses to go. So in terms of attribution, I'm hoping that'll help answer your question. It's like the big wild card. And retrospectively, CMS goes back and looks at the claims and says, yep, you had 2 over there, 1 there, 3 here. Oh, you go along to that one you had 3 at. Next year, it could totally change. And the latest stats I've heard about churn in these ACOs is about 20% of the population churns every year. So based on patient choice, patients choose to go to different doctors, patients move, patients do whatever patients do. 20% of them are going to churn out of the ACO every year. So managing the risk of that is key to success as an ACO. You get a benchmark from CMS that says your patient population, based on who we think will be attributed to you, should cost you about $1,000 a month. So if you can service these patients for under $1,000 a month and get the same cost, same quality, you can keep the difference-ish. But that's the basic premise. So they're trying to manage to the attributed population CMS has estimated they have, set their benchmark, and then they have to go back and figure it out. And actually, the benchmark is based on historical claims as well, with the assumption that patients tend to stick to their doctors. So there's a lot of stuff in there that made it very confusing and hard in the beginning. And I think a lot of the ACOs are still trying to manage it.
Yeah, so I can take one. How do you identify ACOs in your marketplace? So we have functionality that will allow you to select, whichever ACO you're interested in, and it actually tells you all the providers there and gives you the metrics for those ACOs. We're also working on functionality for growth. that will allow you to see all the providers, as also which ACOs they're affiliated with, and then eventually identified by ACO and which providers are in those ACOs. So we have that functionality that we're building out in, have available and expanding on in Mosaic.
Next one, this is a good one. Are hospitals who are in an ACO still required to allow patient choice upon discharge? The answer is yes. So that's part of the fun and part of that attribution model. They can make recommendations, and if the hospital is part of an ACO, they are more than likely going to recommend the preferred provider as, you know, someone we know, we trust their services, we think they do a good job, we happen to know they have an opening, whatever that is. But they can't say you have to go here because you're part of an ACO. In fact, members don't necessarily even know they're in an ACO. That's happening all behind the scenes in the claims data. So they still have complete freedom of choice. Let's see, another one. What is the difference between patient diagnostic mix and inpatient MSR-DRG breakout? The patient diagnostic mix in, I'm assuming this is in MarketScape. I'm going to defer that question. I'm sorry, I picked it up, but I'm going to defer it because I want to make sure we check with our data folks. I believe one is a different algorithm detecting groupings of conditions versus the standard CMS MS-DRGs. So we'll look at that and get the data folks to weigh in just to make sure we don't make a mistake into what we tell you, and we'll be happy to respond to that. What else do we have? How would a sniff, oh, go ahead.
No,
Sorry.
I was just going to say we have a couple of minutes left, so we could
goodness.
probably take one more and then wrap up.
Okay, well, here's the most recent one. How would a sniff enter into a DCE? So the direct contracting entities are using tools like Mosaic to see who's out there and who's servicing their patients and looking at their value. If you were to find the DCE list, you didn't hear this from me, but it's posted on CMS's website. So you can see who is participating in the implementation period. If I were a SNF, I would be looking at that list. I would be starting to understand what areas of the country those SNFs are, or those DCEs are in. I would be looking up their data and trying to understand how I perform in their potentially attributed population, and I would be looking to have conversations with them about how would I become a preferred partner with you in this practice. Some of them are starting with just professional claims risk. So they're still going to need preferred partners because they have to manage the patient through the care continuum, but they don't have the same level of risk as the global capitation. So starting now with those DCs that are just starting to get into the game, as the time goes on, they will be looking at their network and trying to optimize it. And maybe just as a final note, one conversation we had with an ACO leader in Florida, where there's a lot of activity, a lot of seniors, it's a pretty saturated market. He said that when he first started their ACO, they had 75 SNFs in their ACO that they were sending people to. So when they looked at their claims data, they're like, wow, we send people to 75 different SNFs. When they got into second year of the ACO, they were determined to narrow that market down, and they were able to create a preferred partner network of 15 SNFs. So going to those ACOs and getting in front of those people and understanding how you can partner and support them and building the trusted relationship you need in order to have that preferred partnership is going to become important, because they will start making choices. Now, that doesn't mean every patient's going to go to the SNF they want them to, but people do listen to their doctors, and they do listen to recommendations from their physicians. So. But with that, I know we missed a bunch, and I apologize that we didn't get to all of them, but we're thrilled you had that many questions. We're absolutely thrilled that you were here today with us. Thank you for joining us. This has been recorded. We will put this out for people and for common consumption. Sam and I are, here on the Product Trella team, and we are thrilled to be here and help you with however we can in this new world. And we learn from you as much as hopefully you learned a little something from us today. So we'll keep the dialogue going, and we'll reach out with the other responses to questions as we come. With that, Sam, any last words before we sign off?
No, thanks for joining. Thanks, Rebecca, for your wisdom and knowledge, and Sarah. We will answer the questions we didn't get to, and we'll get back with you. And for those that were interested in demos, we'll get back to you as well. Thanks so much, and have a great day.